hopefully you'll find this to be somewhat of a toolkit for implementing a new service and tracking outcomes. So we have quite a few people in here that are probably entering the job force. So the first thing I want to ask is, how many of you have accepted a position where you may be responsible for either modifying or implementing a new service? See a couple people raising their hands. This is something that I think we're going to be seeing more and more in the future as we're trying to change our practice models. So we'll talk a little bit about how do you identify what care models you can implement and what services are going to be important to go along with this. So at the conclusion of the presentation, I'll hope to identify new service area opportunities. We're going to list some different programs that pharmacists can implement, discuss some of the potential barriers to setting up a new program, and the resources that are currently available to assist the pharmacists, as well as recognize various methods for tracking continued improvement of patient care. As was mentioned in my introduction, I am a new faculty member as well as a new practitioner. And part of my job when I started back in August with Wayne State and St. John Health System was to enter into a new ambulatory care clinic. This was both very exciting because the possibilities were pretty much endless, but also a little terrifying. So you are really at a point when you're starting off in a new service like I was, where there are just so many angles that you can come in with the service. So it's really important to do some intensive planning, gain background knowledge of what setting you're getting into, and before you dive into a particular service. In order to understand or to discuss what are some possible practice models that pharmacists can enter into, it's really important to talk about what's the evolution of the profession of pharmacy. And I'm sure you've heard a lot about this today. So we've moved as a profession from a product-oriented profession to a patient-oriented profession. We're doing this by increasing our involvement in direct patient care. So there's this push towards having pharmacists be more involved in direct patient care, as well as provider status, so that we can more effectively fall into this role. The Centers for Medicare and Medicaid Services have actually recently revised their conditions in 2012 that actually made pharmacists as eligible candidates for medical staff with privileges to practice in a hospital. So what does this mean? We were actually doing a lot of this to begin with, but it is a recognition of CMS, of pharmacists' ability to work freely within their scope of practice in a health system. So we're seeing that there's a recognition by these bodies in the government for pharmacists to really work in these roles. So since we're providing more direct patient care, there are so many different avenues a pharmacist can really take once we've left our pharmacy school training. And how do you really know what's the best role for me? Well, a lot of you are here because you are entering a residency or completing a residency. So you've gone through the PharmD degree, the licensure process, and postgraduate training. There are so many different types of postgraduate training. So you're either going to be in a PGY1 or PGY2 if you're sitting in your seats right now. But there's all sorts of certificate programs that are available as postgraduate training. And these are all really going to depend on what role are you going to have once you come out as a new practitioner, and how is that going to fit into the services you're going to be providing. So what we're seeing more and more is that these types of postgraduate training programs are really going to become the baseline of what pharmacists must have in order to participate in these direct patient care services. Going beyond that, we're starting to see a lot of qualifications required for board certification as well as added credentials. Many of you are familiar with the Board of Pharmacy Specialties, which most pharmacists going to the clinical environment choose to go down that route. But there are many different other credentials that are available. So again, this is really going to depend on what is your future role as a practitioner and what's going to serve you as a new practitioner in your service site. Talked a little bit about the Pharmacy Practice Model Initiative. in a couple of the presentations prior to mine. But what's interesting to know is obviously we have these organizations representing our profession that want to promote our profession as direct patient care providers. So the Pharmacy Practice Model Initiative through ASHP's goal was to advance the health and well-being of patients in their hospitals and health systems. So this is a really great resource for health systems to look to find what is an optimal practice model that we can promote in a particular setting. They do recommend through these goals that credentialing and privileging processes for pharmacists should include scope of practice for prescribing as a part of the collaborative care team. So being able to optimize regimens as well as prescribe regimens based off particular patient cases is really important. So as we move towards that provider status, we're going to see the need for this continue. Pharmacists should also be a part of accountable care organizations and medical homes. So we'll talk a little bit about how we are fitting into these roles and how this is going to expand in the future. So there are so many different care models that one pharmacist could choose. And it's really important to, first of all, know what is available, what are examples of successes in other health systems around the nation in order to first determine what's going to suit you best as a new practitioner. When I actually was starting my new role into the Family Medical Center, this was something that I really wanted to take care in planning because as a faculty member, I have students and residents on rotation with me. So how is my determination of care model in that clinic going to affect the training of those students and residents? How is it going to affect the other practitioners and other services that are already being provided in the clinic? So we'll talk a little bit about some inpatient care models as well as some ambulatory care models. The ASHP 2008 National Survey actually had pharmacy directors respond to what they felt like were essential pharmacy services. And listed on the slide are actually what were 75% of pharmacy directors' responses. So you'll see some usual suspects: medication dosage adjustment, review of medication orders, daily patient-specific profile review. Obviously, Dr. Kelly did an excellent job with the care transitions talk. And you'll see here that back in 2008, our pharmacy directors were recognizing that med reconciliation on admission and during changes of level of care was also an essential service. So when you're determining what service you want to provide or implement in your practice area, it's important to try to figure out how can I incorporate these types of things in my regular flow and responsibilities. What's going to be feasible to incorporate, make impact on our patients, as well as being able to continue on with some of your more traditional roles as a pharmacist. Another aspect of this that was deemed to be essential was collaboration with multidisciplinary teams. And I think we do an excellent job of this already in our inpatient settings, and definitely in the AM care setting is expanding. So we're starting to see more AM care pharmacists working with their fellow teammates, physicians and nurse practitioners, in collaborating for overall patient care and outcomes. So to review some models of inpatient and acute care practice, there's several of these, and some of these are some more traditional roles, as well as some less well established roles. So the first very traditional role would be academic rounding. So this is your typical team-based approach. It provides face-to-face contact with the physicians and other providers on that particular service, which allows making interventions very easy. It's something that I think is well recognized and many of us are already doing. So that is a pretty good role for pharmacists to move into. I think that if you were starting a new service or in a new service area in an institution, this would be a very smooth transition. There's community-private practice, which is relatively similar to academic rounding in the sense that you're going to work very closely with a private physician in the inpatient institution. This can be team-based or individual, and there are several different ways you can go about providing this service, whether it be a face-to-face contact or indirect contact, where a pharmacist may be following particular patients. and contacting physicians based on specific interventions. We have targeted care, which is actually defined by a service offered. So this can be your anticoagulation service, a pharmacokinetic service. It's really important to identify what are we already doing in our institution and maybe what is missing in our services that we can really target a specific population. The nice thing about this type of service is that you have a team of well-trained pharmacists and a specific aspect of care. And it's a population-based, so you can cover the majority of an institution's population, whether it be in a coag or PK. There are some dual roles, and this is a patient-centered integrative model. Again, I think that we see a lot of this in our institutions right now. So it's where a pharmacist is participating in distributive and clinical functions. So the patient is actually being cared for through all aspects of pharmaceutical care, perhaps by one particular pharmacist. Lastly, we have population-based care. This is an interesting way to actually implement protocols, guidelines, and pathways. So it's less of a direct patient care role. However, there are a lot of benefits to establishing these types of protocols in order to identify common drug-related problems as a patient group and looking at overall outcomes for particular patient populations. So I have here emerging practice areas of inpatient acute care. A lot of these things have been done in some of the larger institutions. So they're maybe perhaps not as new, but I think that there is a lot of room for expansion on the inpatient side. And I am by no means an inpatient expert. I am an AmCare pharmacist. But emergency medicine, we see a lot in our larger teaching hospitals. However, if you are in a smaller community hospital, there is a lot of room for pharmacy intervention. So there's a high preventable rate of adverse drug reactions and a lot of room for patients to receive pharmaceutical care. Antimicrobial stewardship, we know that the Infectious Disease Society of America and Society for Healthcare Epidemiology of America actually have in their guidelines that they think that clinical pharmacists are core members of this team. Again, this is not necessarily a new service, but a place where we can try to implement in all types of institutions, whether it be our community or academic teaching hospitals. With the advent of having more hospitalist physicians, there is a room for pharmacists to become more involved in these roles as well as the patients that hospitalists are caring for. So this can actually be done as a consultative service. Pharmacists can provide medication management under a collaborative practice agreement, and it's a way to focus in and work very closely with the hospitalist pharmacists, which may be more difficult in an academic teaching or rounding type role. Something that's considered inpatient, or actually acute care, would be a hospital-based clinic. So it actually falls into inpatient care. But we're seeing a lot of medication therapy management clinics being done within the health systems and continuity of care services. And this is really actually a great place to have this type of service. So the patient is just recently being discharged, and having this type of hospital-based clinic fits in nicely because the pharmacist will have access to the inpatient records, understand what was the flow of the patient's care while they were in the hospital, and provide some of those continuity of care services. And I'm not going to spend a lot of time on that. I know Dr. Kelly did an excellent job talking about continuity of care. Then there's lastly quality of care services. So this is where pharmacists can really participate or lead hospital committees. Again, this is less of a direct patient care role, but it's really a good spot for someone to develop or implement practices in quality improvement or collect and analyze data pertaining to performance measures. So this can really actually be in any setting, and I think that this provides a lot of room for some interesting and novel services that can come out of quality of care services. So we'll move on to the ambulatory care practice models. And there's several different ways you can look at AM care practice models. So we can have pharmacist-managed clinics. Pharmacist-managed clinics can be within a larger, for example, family medicine clinic or internal medicine clinic, where the pharmacist is actually seeing patients independently. So you may be managing a specific condition within that pharmacist-managed clinic. So, for example, my pharmacotherapy clinic in the Family Medicine Center is a pharmacist-managed clinic where I see patients independently of the providers. And we focus on specific disease states based on referral. So this is a good place to nest within a larger clinic, or it can also be done as a standalone pharmacist-managed clinic under a collaborative practice agreement. The second type of service is collaborative services. So this is where you work within the flow of the clinic. So if you are working with physicians or residents, your services are being provided within that actual patient's visit. So whether you're going in and seeing the patient prior to them seeing their physician, conducting a med reconciliation, educating the patient at the end of the visit on new medications. There's really numerous aspects of this type of model that you can incorporate. And I actually do have a somewhat of a mixed model with my service, where I have the pharmacist-managed clinic on one day of the week, and then I work with residents and work within their flow of care, seeing patients the remainder of the week. So getting to know patients and getting to see patients within that flow can also provide a route of referral into a pharmacist-managed clinic. So if you're seeing a patient with a resident who has uncontrolled diabetes, and you think that they would really benefit from seeing one of the pharmacists in the pharmacist-managed clinic, that, by the way, can be a route for referral for a patient to come to see you. So it's really good to actually have a combination of both, and that way you can provide that continuation of care within that specific clinic. Disease state management, it's pretty similar to pharmacy management clinic in the sense that you're going to be managing a single condition. So for example, if you're having a diabetes clinic, you will manage that single condition, focus on what are the diabetes measures the patients need to achieve, as well as some of perhaps the comorbid conditions. So you're going to look at hyperlipidemia, hypertension, but really you're not really going to focus on perhaps the patient's depression or anxiety. So this is a way to be able to focus in on a specific patient population and focus on a single condition. Obviously we are pharmacists, so if you are seeing patients in a specific disease management setting, you're going to be looking at the patient overall to see there's no glaring errors or glaring drug-related problems, but you really get to focus in on that specific condition. The second or alternative way that you can go about implementing a service is more comprehensive care. So, for example, in my clinic with the residents, I try to provide more comprehensive care. So we're looking at the patient as a whole. We're going to medically manage the whole patient, each disease state, as well as think about preventive care. So in the AmCare setting, we do have the luxury of thinking about, what's going to happen 5 years down the road. So thinking about pneumococcal vaccination in patients with diabetes, or mammogram screening in patients who are at risk. So those are the types of things. You're going to look at the patient as a whole and perhaps can provide more comprehensive care along with your physicians. I think that the comprehensive care works very well with patients who are being seen, or with the service that you're seeing patients with the physician or the resident. So this works well within the flow. You can have that collaborative care with the physician or resident and really focus in on the whole patient. So this slide is just kind of demonstrating what types of practices as a pharmacist can you as an AmCare pharmacist function in. So functioning in a family medicine clinic or an internal medicine clinic, is really a broader range of patients. So the benefit of being in this type of setting is that you can really kind of take your pick on what types of services you want. So if you're in a family medicine clinic, you may potentially see a lot of women's health or a lot of diabetes or hypertension. So it's going to be really important to first of all determine what's the greatest need, what's our highest risk population, or perhaps what do our physicians think that maybe they're not doing so good of a job on or need some extra help in managing specific patient populations. So the possibilities are endless. The one thing I would say about when entering into a general practice is that you have to be careful to not put yourself into too many different services, especially initially. I like to say start low, go slow. You want to try to pick one or two essential services and really identify if that service is going to work within that clinic and within that flow of that clinic, and then expand from there. So when I started at the family medicine clinic, it was really quite overwhelming. I sat down with the physicians and they said, "This is so great, we've never had a pharmacist before, we want you to do all of these things. We want you to do anechoic, we want you to see our diabetes patients, we want you to do med rec," and it's exciting, and you want to jump on all these opportunities because you're just getting started and you really want to have the most impact. But you have to be careful because if you spread yourself too thin, you need to think about the quality of care you're providing to your patients. So you want to try to focus in on something or one or two things initially and do a good job on that, and then consider expanding further, which might even require more pharmacists or extra pharmacy students or pharmacy residents to help you provide that care. You can move into a specialty practice, which may actually help you to have more of a focused service. As a resident, I participated in a heart failure clinic, which had very specific needs. So they were looking for pharmacists to really conduct thorough medication reconciliation, provide medication education as well. So it might be a little bit easier to identify one or two specific services in this setting. The only barrier to this potentially could be that you may not have as many opportunities to expand if you're in just one setting. Lastly, you can go into medication therapy management. So this can be within pharmacy practice, physician practice, community pharmacy, and I won't go too much into it. But this is also another avenue that we're seeing pharmacists entering into. It's a billable service, and it's something that we as pharmacists are very well equipped to do. So we talked a lot about care transitions, and this is definitely an emerging role for AmCare pharmacists as well as inpatient pharmacists. The continuity of care, med reconciliation. I won't spend a lot of time on this as we had the presentation earlier, but I think really in any aspect of your career, you're going to have contact with this type of pharmacy services. Comprehensive medication therapy management. This is just in relation to the patient-centered medical home. So pharmacists functioning within a certified patient-centered medical home, just providing really your medication therapy management for those patients, looking at the patient as a whole. That's going to be your comprehensive care model. So those are things that we're starting to see, and with the hopeful, with us being hopeful that we will have provider status in order to perhaps practice a little more independently in these types of settings, we'll probably start to see this role really expand. Another area that's really expanding is population-based management. So with accountable care organizations as well as patient-centered medical homes, we're doing a lot of tracking, keeping patient registries, seeing whether or not patients are meeting their goals. And I think this is a great opportunity for pharmacists. So if you're entering into an AmCare setting where you have access to a registry of patients not meeting their A1C goal or patients not meeting their hypertension goals for blood pressure, you can actually manage these patients on a population standpoint. So you have 10 patients on your list who aren't meeting a particular goal. That's something that you can comprehensively review, send recommendations, or discuss these recommendations with the physician, and perhaps schedule some sort of follow-up or intervention with the patient. So it's a good starting point. When I was coming into my role at the Family Medical Center, I had access to these lists. So the very first thing I did was look at the patient registry of all patients who were diabetics, not meeting their LDL goal, not on a statin. So why weren't these patients on a statin? So I had the opportunity to kind of go through this list, review the chart, determine if this was an appropriate type of scenario, and then make recommendations to the physicians. It was quick, it was easy, and it made good impact. The physicians really valued that type of quick intervention, and I was able to cover a large group of patients within that practice. So this slide is just really depicting the intense need for care transitions and pharmacist involvement. Again, I'm not going to spend a lot of time on this, but it's just showing that when a patient transitions from anywhere, from the clinic to a long-term care facility, to a skilled nursing facility, or back and forth, there are so many possibilities for error, and this is really a role that pharmacists can play in trying to minimize these through some of the services that we've already discussed. So now that you've understood or looked at some of the care models that you could potentially choose from, how are you going to plan and implement a new service? Where do you start? And this is somewhat, it's somewhat overwhelming, but if you plan very carefully and really do your homework in determining what are the service needs in the area that you'll be practicing in, and looking at what are the existing services that are there or gaps in care, you will find that you'll have good success. And I think one of the biggest pieces of advice is to really go slow in your planning, making sure that you've thought all these things out very carefully. So one way to look at the planning and implementation of a new service is using the Plan, Do, Study, Act method. So this is a continuous cycle. So you'll see here, it's not a straight line. You're going to plan something, you're going to perform the service, you want to study that service, and then you're going to do something about it. Are we going to continue on? Was everything okay with what we did? Or maybe we need to tweak our service a little bit. So we'll go through each of these steps and how this will really relate to implementing a new pharmacy service. Some things that you want to do when you're in the planning stages, there's a few questions. So first, what are you trying to accomplish? So are you trying to lower hemoglobin A1Cs in diabetics with a A1C greater than 9%? Are you trying to get all patients who are on an ACE inhibitor, make sure that they have their potassium serum creatinine checked on a regular basis? So you need to determine what is the service, what are you trying to accomplish, what's the ultimate goal? And then how are you going to know if the change is an improvement? These are all things you want to think about before you even start implementing your service. What is going to be your marker for improvement? Depending on the service, some of these are going to be more obvious, but it's really important to figure this out ahead of time. That way, when you go back and do quality assurance and investigate your outcomes, you really do have an idea of what you're looking for. Lastly, you're going to determine what changes that you can make that will result in improvement. So you're going to see diabetic patients. Great. What are you actually going to do when you see them? Are you going to counsel them on diet and lifestyle? Are you going to make recommendations to adjust therapy? Are you going to do all of those things? I think you really need to make sure that you're thinking out what are the steps when I see this patient, or what are the ultimate goals for each individual patient for that particular service. So there are several steps you can break down in the planning stages. The very first step is establish your philosophy of practice. And what this really means is, what do you as a practitioner, what are your values and your goals in practicing as a pharmacist, and especially providing direct patient care? Secondly, you want to understand your practice environment. And this actually is probably one of the most important things that you can do in preparing to start a new service. So really take the time to, first of all, identify key stakeholders that are going to be involved in this type of service. So those are going to be your physician champions, your management team in the Department of Pharmacy. Who are the people who are going to want to see outcomes and what do they think is an important service. So when I was starting my service, I spent quite a bit of time meeting with physicians in the family medicine clinic, trying to understand what their flow is, what the history is, what services are they providing currently. Are there nurse practitioners there? How many residents are there? What types of things are they doing? Because the worst thing that you can do is go in and just assume, well, this, everyone wants help with their diabetics, so I'm just going to go in and do diabetes. Well, perhaps that may not be the case for that particular clinic. Maybe they have a need for patients to be managed for their anticoagulation. So it's a good idea to really understand what's the practice environment, what's the culture, how accepting are the key stakeholders going to be of this new service. Step 3 is understanding the expectation of your major stakeholders. So you want to make sure you're really just on the same page with the people that you're going to be working with. Are they expecting that you're going to bring all their A1Cs down to goal for their entire patient population? Would they be happy with a 10% of their population reaching goal? Those are the types of things that you want to have a clear understanding of their expectations. Do they expect that when you have a student on rotation that they're doing a med reconciliation on every single patient that comes into the clinic? So those are, when you're in the planning stages, you really want to be able to understand these things and have a conversation. That way there is some sort of negotiation between what you really want to do and what the clinic or inpatient service really needs from you as a pharmacist. Lastly, in the planning stages, you're going to use your information to develop a practice plan. And this can also take quite some time. You might have a plan and then go to your key stakeholders and they'll say, well, that really wasn't how I was envisioning it, or maybe we can do this. So you can do a lot of back and forth with developing your practice plan. So the preparation is really going to make a big difference. So when we're planning, you want to establish goals, and you've probably heard a little bit about SMART goals. And this is just a nice acronym for making sure that your goal is specific. So what's your goal? To lower blood pressure in hypertensive patients? Okay, so how are we going to measure it? Well, that one's pretty easy. You probably would measure all your overall blood pressures after a particular intervention. Is the goal attainable? So are you going to see, if you're doing a post-discharge follow-up, are you going to expect to see 30-day readmissions declined after your first 6 months of service? You want to make sure that you have an attainable goal. Is it a realistic goal? Are you going to be able to actually see the entire patient population in your identified service? Or do you think you'll be just treating a particular segment of that population? And then is it timely? So are you going to be able to complete that goal in a timely fashion and be able to show some outcomes in order to either continue that service or to further expand? So just some things to keep in mind. We talk a lot about provider status and pharmacists working in direct patient care. So how do we know if we need a collaborative drug therapy management agreement? And I think this is kind of interesting. So in the AmCare world, we pretty typically will go ahead and implement something like this. But what about inpatient? Do you necessarily need it? Do you need it in every type of service you're providing? So just some general loose rules. For example, if you're rounding with the medical team and providing recommendations, you probably don't need a collaborative practice agreement. However, if we're moving into independently writing orders without co-signature, laboratory orders, medication orders, or providing referrals, you may potentially need to establish that collaborative drug therapy management agreement. So you really need to take a look at the service that you're implementing and determine if this is something that is a necessary aspect of care. Also, if you're going to be charging for patient services, this may be a good idea to have something outlining what are your services, what are the expectations, and what are the general goals and outcomes of that service. So what are some things, if you were to incorporate a collaborative drug therapy management agreement, that you would need to include in that agreement? So before we get into that, how many have in their residency training or student training functioned in an area where a collaborative drug therapy agreement was in place? Okay, so pharmacists and providers participating in the agreement. And really you want to make sure you're describing the types of services that you're providing, where it's being provided, the circumstances and guidelines or protocols that are going to be included in the service. If you are staying in the state of Michigan, there are specific state requirements, and that's going to vary depending on what state you ultimately practice in. So for Michigan, there's actually no collaborative practice provision, but you can actually implement a collaborative drug therapy management protocol based off of the Michigan Public Health Code, which allows physicians to delegate their tasks in his or her scope of practice to other healthcare professionals. And I think sometimes that can be what may be viewed as a barrier when implementing these types of services, is the background knowledge of knowing that although we don't have the collaborative practice provision, that we can do what we're doing because of this ability for physicians to delegate their tasks. And I actually, in my collaborative practice agreement, have this actual line stating this is the provision under which I am able to provide these services. So it's really important to kind of understand what are your state regulations. So moving on to the actual doing. So you've now planned your whole service and you're ready to go. Well, what's your next step? You're going to need to market yourself. So who do you market yourself to? That's really going to depend on the service you're providing. If you are providing an AmCare service, it might be a good idea to actually market yourself to both the physicians as well as your patients. For example, in the clinic where I practice, we have pamphlets in the waiting room for the pharmacotherapy clinic that kind of lists what are the services and benefits to a patient wanting to attend that clinic. And then also, we did a lot of marketing within the actual clinic itself. So attending specific physician meetings where the providers or physicians that will either be collaborating and working with you will be, as well as those who potentially may be referring patients to you. It's just really important for them to know what you're doing, why you're there, and how you can help them. So it's important for you to identify who are the key people that need to know about my service, and how are we going to spread the word that we're here and available to do these services. Lastly, for step 6, you're going to implement your service. So this is the fun part. So you've finally identified who you're going to see, what service you're going to provide, and now you're going to do it. So you just need to understand that when starting off a new service, it could potentially start off a little slow. And that's okay. You want to keep going and keep that initiative rolling, because eventually it's going to pick up. And I'll tell you, really, when you're working with physicians, it only takes really one good patient experience for them to have buy-in in the service. So, one patient you see and you've made a good impact on them, and the physician might already be sold on that service and start referring all their patients to you. Moving on to the Study Act, and this is actually probably one of the most important parts of implementing and planning your service, because you need to evaluate the services you're providing, and it needs to be done in a very specific time frame. So at 6 months, a year, it really depends on what type of service you're implementing, but how are you doing, and what outcomes and impact are you having on your patients? This is really going to let you know that either things are going great, or maybe we need to make some adjustments or tweak some of the services that we're providing. And that's where really step 8 comes into play. So once you evaluate your services, you're going to determine your changes and improvements needed for full implementation. When you're evaluating your service, I will tell you that it's probably a good idea, actually when you're in the planning stages, to determine how you're going to track your outcomes. So does your institution have a pharmacist intervention tracking system? Is it something that you need to create or tweak based off of the service you're providing? It is much easier to do this at the beginning of implementation than to go back retrospectively and have to determine whether or not the services that you are doing have impact, or to even remember what interventions you had provided to a patient 6 months ago. So really important to try to plan that, because it'll make things much easier when you go back from a quality assurance standpoint to track these types of services. And then lastly, step 8, this is really where that cycle comes in. It's begin either your full implementation of the service, or maybe you need to go back to step 1. Either you need to completely restart with the new service, or there's just some tweaks or adjustments that you want to do. But you do want to remember that it may take a couple rounds for you to make some adjustments until you really feel satisfied. Also understanding that the climate of overall healthcare is going to be continually changing. So your practice today may look very different in 5 years from now, just based off of the needs of patients, the needs of the clinics or health system. So you need to understand that you're going to probably be continually doing this type of process throughout your career, more or less. So we're going to talk about some bumps in the road. So what are some barriers to implementing a new service? One of the very first things that could potentially be a barrier is communication. And that's something, as pharmacists starting out in a new service, you want to make sure you have clear communication with your key stakeholders, your patients. And when you're in these interactions, you must be professional and on in all of your interactions. So it really only takes one bad situation or one bad interaction with either a physician or a patient to lose that trust and that integrity as a provider. So when you're establishing these roles and relationships, it's really important to be professional at all times and understand that building these types of relationships do take time. It takes time for the physician or the patient to really establish that trust in you. Unclear roles can also be a problem, and really this can be avoided by careful planning. So does the physician or the service or the team understand what your goal and what your role is in providing that service? So marketing yourself appropriately and understanding what's important for them to know about what you're doing can really avoid this. There can be time constraints. So time constraints can be in various forms. So whether you on a timeline for implementation of a service and perhaps you didn't have the luxury of spending a lot of time planning and doing your background work, or time constraints in how long you can take in waiting to look for patient outcomes. So those can all be some potential barriers. There could be financial incentives that may be barriers. So Amy's going to talk about reimbursement and billing, so I won't spend a lot of time about that. But it could potentially be a barrier. So when I initially started at the Family Medicine Center, they were actually very hesitant to allow me to bill even as an incident to a referral. So and I won't go into too much depth about that specific billing, but they were concerned that patients may be hesitant to pay a copay for a pharmacist service. And I think that really speaks to the fact that do they value what services or even understand what potential services that we can provide as pharmacists. And what my ultimate goal is now that we're 8 months out providing these services is that I can go back to them and say, these are the outcomes I have with the patients I've been seeing. And now do you think that this is important enough for us to perhaps bill for services? And you can actually, and then the clinic will actually get that kickback or get that financial incentive. There's also a concern for liability. So when we're dealing with delegated authority, some physicians might feel uncomfortable delegating authority to a pharmacist because they may not be used to that particular role. So another example is the physicians in my clinic were a little hesitant to allow me to go ahead and just optimize therapy on my own, so modify or discontinue drug regimens, because they weren't sure that I would really have the whole background knowledge of the patient. And I can tell you, after seeing a couple of patients, that concern went away. So it's really important to really work on those types of things and understand that if there are some hesitations initially, that we're well trained to be able to show that we can directly care for these patients, and you'll start to see that buy-in come in over time. There are some mistakes to avoid. So you want to make sure that you're seeking out the needs of the institution or the practice. So this goes into the whole planning stages. So what does the institution need from you? It's great. We can have all these wonderful ideas for services. What would be your ideal setting? For me, I really would have loved to just see diabetic patients. Well, I went into my clinic and I saw that they also needed help with their post-discharge med reconciliation and transitions of care. So that was an identified service that, although I wanted to focus on one thing, I also identified that the clinic is requiring an additional service. And you really want to provide those types of things, or at least find some sort of solution to answer to those needs. You don't want to step on anyone's toes. So what this means is there other providers in the clinic that are maybe doing a type of service that you're proposing? We have a clinical nurse in our clinic, and she provides care for anti-coag patients. So if that was a desire of mine to work with that patient population, you really are going to want to talk to that person who's already providing that service and see, is there a need for additional help, or does she feel that her service is running smoothly? So you don't want to overstep in and just get in there and do everything that you want to do. You should also know your limits. So this really speaks to what can you feasibly do within a service? How many things can you provide? Sometimes it's quality, not quantity. So there's a lot of things we can do, but choosing one or two things that we can do very well is probably the best way to do it, especially if you are operating in a role where you're just the one pharmacist. You also don't want to overstep your boundaries, and I think this really speaks to how important it is to provide communication at all times, especially when you're initially setting up your service. So I actually tend to, I think, over-communicate, making sure my physicians know exactly what's going on with their patients, what I've done, and then slowly you can, as they learn to trust you or build those relationships with you, you can kind of slowly back off and maybe not have to tell them about every single thing that you're doing. But I think that if you over-communicate, that might not be a bad thing. Okay, so we'll talk a little bit about tracking outcomes. And tracking outcomes is very important from a quality assurance standpoint, as well as from a publication standpoint. So if you're doing a novel service, why not demonstrate what you're doing in the literature? And I think Dr. Clay talked a little bit about, talk about what you're doing, get it out there, make sure other health systems or care settings know what you're doing. So we track outcomes because it's an important part of the overall business plan. Obviously, we want to make sure what we're doing has a positive impact. We want to ensure overall continued growth. And there's actually several outcomes that you can track. So there's your clinical outcomes, humanistic, as well as economic outcomes. And I actually think that they're all very important in the overall picture of the service you're implementing. It's also important to have a timeline that's dependent on the service, disease, or problem addressed. So, it's going to be dependent on what you're providing, but you need to make sure that you're giving yourself enough time to show impact. So when you're tracking outcomes, you can actually just look at the number of clinical outcomes that can be measured, like laboratory parameters, for example, hemoglobin A1C in patients with diabetes, or physical assessment parameters, for example, blood pressure and hypertension. So these are typically your clinical outcomes that you're going to want to assess. And there are several ways that you can look at these outcomes. These measures can be compared to the baseline of that patient population that you were seeing, a group that's not exposed to the service. So perhaps you have patients that have similar conditions on another floor that the service is not being provided in the institution, or you have just a group of patients that weren't receiving your care. And then you can also compare this to internal standards, so specific healthcare standards and outcomes. There's also external standards, so certain standards set by guidelines or benchmarking data, and these can all be incorporated into your overall outcomes. Other things that you can look at is comparing these patients at specific time points for continued quality improvement. So how well over that time period that you were seeing a patient did you improve a specific goal? Humanistic outcomes, I think we actually often overlook these types of assessments, but it's actually very important. And they're basically assessing the impact of a service on a specific disease or problem. So how well was the patient satisfied with your service? Did they come to see you for their diabetes but kind of felt like it wasn't so important to come to that visit? Or did they find it very useful? And a lot of these things can be assessed before the patient comes to see you, after they've been with you for a few visits. And this type of assessment can be done as a Likert scale. So the pharmacist increased my knowledge of the problem disease state, and then it can be a 5 for strongly agree or a 1 for strongly disagree. And you can really gauge on how well you think your patients benefit from this service. You can also survey your providers and other healthcare professionals for provider satisfaction, and this is something I'm planning on doing very shortly with my providers. Now that we've implemented our service for a specific amount of time, I want to see, are they satisfied with the services I'm providing? Was there something that they were expecting that was different and that maybe we can add or change? So that's all going to play into those types of outcomes. And we won't spend a lot of time on economic outcomes, but you can really look at the 4 different types of evaluations, and it's going to depend on the disease state. So is it effectiveness? Is it a benefit? Did you have a cost minimization or cost utility? And this is going to depend on the setting. Another aspect, which is we see a lot of times in the literature for pharmacy, is cost savings. So did you decrease direct costs or indirect costs, and how does that affect the overall picture? For really all outcomes, but especially economic outcomes, it's really important to document your interventions to look for your impact. So I think this was covered as well in Dr. Kelly's presentation, but you need to document what you're doing so that way you can actually obtain maximal benefit from patient impact as well as looking at your economic impact. Sometimes it might be difficult to assign a specific dollar value, so you have to look for cost avoidance, and those types of things can be found in the literature depending on the service that you're providing. There are also some software programs that attempt to assign cost savings for each intervention. So those are types of things that you can think about implementing when you're implementing your service. So I won't spend time on revenue generation, but there's several different reimbursement structures that you can look to, and we hope that this type of thing will become a lot easier for us in the future if we do gain provider status. We will be able to have an easier time obtaining reimbursement for our services. So lastly, the recent changes in healthcare provide opportunities for unique practice models. And I really think that it's an exciting time in pharmacy because there are so many different avenues that we can venture down as pharmacists that are really going to create positive outcomes. So our pharmacy practice model is really changing and expanding. One of the most important things is to have buy-in from your key stakeholders. And you also must carefully plan. So planning, doing the actual service, studying, and then making adjustments based off of that evaluation is going to be crucial into the success of your particular service. Lastly, revenue generation may be challenging, but hopefully after Amy's presentation it won't be so mystifying. And this all may change actually with provider status. So with that, I'll take questions. And I know you're probably all very excited to get to lunch. Yes?
I know you mentioned, about keeping a narrow scope. Is there something that, in hindsight, that you would do differently when you looked at starting a new service?
So I gave the advice of making sure you understand what your providers deem as their most important services that they would like you to provide. And I think when we started out, there was a lot of excitement for all these types of new services, and I think it was kind of hard to discern what they deemed to be the most important. So I think being really straightforward with your providers and saying, what are your top 2 things that you really think that I could help you do? I think I would go back and actually ask them to narrow that down, because after a few months of implementing my service, I was starting to realize that they were coming up with some other things like, oh, we can also have you help with the anechoic patients, and we would really like you to do med reconciliation. So although that maybe wasn't as clear that that was maybe some of their top things that they wanted out of my presence in the clinic, that kind of came forth after providing those services after a few months. Thank you.